with you all today about open visitation, or patient-directed visiting as we refer to it. And also thanks to Anne for getting us all together. If you have any questions as we go through, or hopefully if we have some time for questions, you can type them right in the chat window on the bottom right. And if you do have trouble, particularly with audio, if you can let Karen Andazola, who is listed on the top right as host, know that you're experiencing problems. So that's me. I'm Jillian Capiello, Senior Planetree Experience Advisor, and our panel today includes Carol Wall, who is a nurse and the Vice President of Patient Care Services in the hospital here, Good Samaritan in Kearney, Nebraska, and Dr. Stephen Horowitz, Medical Director for Planetree Cardiac Care Management, Stanford Hospital in Connecticut. And we all today represent different stakeholder perspectives and vantage points, and each of us have broad depth and in-depth knowledge and experience with this particular topic. So our objectives for today's call, we are going to define patient-directed visiting to start with. Visiting hours are over is something that's heard so frequently about the same time every evening, hospitals across the United States, and I suspect across the world. Families leave patients' bedsides worried about their loved ones. Patients are left alone. Many feel anxious, isolated. And so cultivating a healthcare environment that really welcomes loved ones and recognizes that family involvement enhances healthcare delivery is fundamental to the Planetree philosophy and the patient-centered approach in our model of care. Today we will define what that is, why it's important, and review some of the evidence to support the challenges involved and how to be successful with that. I want to start out by looking at some qualitative data that identifies why this topic is so important. This data represents the patient's perception of their healthcare experience, and it's gathered through listening to the voice of patients and family members in focus groups work that Planetree does. From the thousands of focus group sessions, tens of thousands of participants in those sessions, several concerns emerge as themes, and access to social support is one of the top concerns. One of my roles with Planetree is in the field with our members, conducting focus groups. And I can just stress that the importance of family presence comes up every single time, every single group. One of our member hospitals, Allegiant Health System, conducted an ethnology project and asked, as they followed patients around, continuously recording interactions, audio, videos, picture journaling, really with the purpose of identifying what were opportunities for improvements and innovation in the facility design and their process design. And this project revealed that the biggest fear of patients who are hospitalized was of being alone. Since the late 1990s, there have been several quantitative and qualitative studies that have been done to assess the symptoms of family members of patients in the ICU. And in this particular review of the literature, the science on symptoms that were experienced by family members of patients in the intensive care unit was reviewed and critiqued. Risk factors associated with an increase in symptoms experienced were discussed, and surveys were largely part of this study. But as you can see, 80% of family members develop anxiety, depression, and or post-traumatic stress disorder related to the experience. There was another survey that was conducted in 2010, intensive care visiting in the United Kingdom, demonstrated that many of the UK ICUs still operate with restricted visiting policies, despite the evidence that the benefits to patients and their relatives from more flexible visiting. Many of the traditional rationales for restricted visiting are not supported, and we'll discuss that in some of the other evidence. This particular study examined the benefits of unrestricted patient visiting, and 88% of families stated that it was a positive benefit in their experience. And research studies elsewhere have found the flexible policies really do minimize that anxiety and maximize the comfort of patients and families. At the end of the slides, I do have some additional research and studies that I will share with you when I send the slides out. Child-friendly visiting is another thing that was studied. As Don Berwick, former administrator of the U.S. Government Center for Medicare and Medicaid Services, or CMS, previously president and CEO of the Institute for Healthcare Improvement, in 2004 he said, despite clear evidence that patient-directed visitation is what patients and families prefer, hospitals continue to struggle with the transition from traditionally restrictive visiting policies to patient-directed visiting. Patient-centered hospitals have addressed and successfully overcome these barriers in order to implement patient-directed visiting. At this point, I would like to ask our patient who has joined us. I'm going to introduce you to Carol Raimondi. Carol is a nurse by training and a patient at Elmhurst Memorial Hospital in Illinois, where she also serves on the Patient and Family Partnership Council. Carol is going to share her own experience from her perspective as a patient. Carol, welcome.
Thank you. Thank you, Jillian. I'm happy to be here to explain my perspective. As Jillian said, I am a nurse, and I've also been a patient my whole life. I have congenital heart defects, so I've been in and out of several different hospitals throughout my life. My home hospital is Elmhurst Hospital, which is about a 250-bed hospital here in Illinois. And they also I go to Mayo Clinic up in Minnesota for more specific care related to my congenital heart defects. In regards to visiting, I have found that, as a child, I always was able to have my mother, present at my side, or some type of family member present at my side. And at a certain age, there's a point where, whether it be because I was a teenager or because, I was too old to have somebody stay at my bedside, it really wasn't encouraged anymore. And at that point, I got used to being there by myself. And then I started doing visits to Mayo Clinic as well. And then when I visited Mayo Clinic, I got married and I have a daughter now. During my visits to Mayo Clinic, I felt the care was excellent and the expertise was incredible, but what I found lacking was, 8 o'clock every evening, my daughter and husband were asked to leave. And to the point of having security come around and make sure that they had left the room. In an area where I wasn't familiar with anybody, I didn't know the nurses because I hadn't worked there, obviously. I wasn't frequently a patient up there. Elmhurst is my home hospital. I felt very alone in a situation where it was more critical. It was following open heart surgery or other serious health concerns. When I was at Elmhurst, though, which is a Planetree hospital, there was a big difference. Despite the fact that it was a smaller hospital, I felt that having my daughter and husband there was greatly encouraged. A recent experience that I had about a year and a half ago, I was in the hospital following some complications related to my heart defects, and my daughter, who was 12 at the time, was expecting me to be home at a certain day, but something prevented that from me. My health prevented me from being home at that certain time. And they have 24-hour visiting, so they actually encouraged her if she wanted to spend the night. And we took full advantage of that, and she was able to spend the night next to my bed, which was a huge anxiety relief for me. Having her right there, I didn't have to worry about her and how she was handling me being in the hospital, and vice versa. She was able to be there and see me. So that was a huge difference from what I'd had up at Mayo Clinic. And even in the past, whereas, when the rooms were smaller or I had other, roommates, it was not always possible. And also recently I was hospitalized and we had a lot of family coming from out of town, and I was able to have a large number of people come and visit me, and it was after visiting hours because they were coming from out of town. And I was able to have them all come into the family room. It was probably 15, 20 people. And just the effect of having them there on my hospital stay was it was definitely a calming experience. It relieved a lot of anxiety I had related to that hospitalization. So I just really can't say enough about the difference it makes when I've had the opportunity to have people come in and out at any time, versus when I had a security guard telling me that family had to go home, and which in turn left me by myself. So I appreciate Jillian and everybody inviting me in to speak, and I hope that my information here was helpful. Thank you, Jillian.
Thank you, Carol. What you've shared here is just, you've spoken, I think, to countless thousands of other patients, certainly things that I've heard. And what Carol's talking about here is changing it from just allowing those who are important to actually creating that welcoming environment, changing from restricted visiting to unrestricted and visiting. So patients are in situations, if the patient lacks capacity, then the patient's health care proxy can establish those visiting parameters, the ones that best suit that individual's circumstances. So flexible visiting is visiting just according to the needs, the choice, the circumstances, and is limited only when it's clinically indicated or when established visiting guidelines are ignored. And we see the advantages with the perceptions of the courteous and respectful treatment, and I think you could hear that in what Carol shared with us. There's also encouraging a family to be that spokesperson. One person sharing can really be helpful. As we saw in the studies and the research that we have seen, a decrease in patient-family anxiety, as well as providing that avenue for family members to really be a participant beyond just the person coming in and visiting. But there are challenges, and it does come with certain challenges, as I'm sure you're all very well aware, and we are going to talk about all those in just a moment. One of the reasons I do just want to say that we don't typically refer to it anymore as open visiting is just what comes to mind when you think of opening. For many people, this is quite fear-provoking, implying that it's unrestricted any time, any duration, any number of visitors, versus the restricting, which is bound by the rules of time, duration, and the number of visitors. So we've moved away because what we're talking about is that flexible. There are limitations in certain circumstances. So concerns range from spread of infection, family members being unruly and impediments. And we wanted to talk a little bit about some of these things, which here it says myth. This happens to be a study that has many studies. This was a meta-analysis that showed that unrestricted visiting in the ICU doesn't increase infection rates and actually associated with health benefits. But there are obviously many other concerns and many reasons that staff or other care providers might see challenges, and some of them are just perception, and some of them are real. And at this point in time, I'm going to turn it over to Carol Wall and Dr. Steve Hurwitz to talk about their experiences and with developing a framework that really supports patient-directed visiting and how challenges can be addressed. Carol?
Hi, everyone. Carol, if you'd like to talk about your own experience. We have Carol.
Okay. Can you hear me? This is Carol.
Yes. Yes, I can hear you loud and clear, Carol. Thank you.
Okay. Well, maybe a good way to really start talking about the patient-directed visiting is to look at the Planetree Standard that really talks about really if you are going to be doing it in an excellent patient-centered way, what would the standard be? And so the standard is that it's flexible, that it is available 24 hours a day, that the patient-directed visiting hours are in place, and children are permitted to visit. Now, we do realize that there are a couple of places where there may be some additional concerns or you wanting to put in some different practices, and that might be true in the psychiatric facilities, in neonatal intensive care, and maybe in some cases when you have communicable disease. This criteria, we used this when we were going for our Planetree designation as a way to really provide a standard of what we wanted to be. And so were we doing everything right? Had we looked at all of the different issues surrounded patient-directed visitation? And so truly this was the standard that we chose to go after.
Oh, it's very interesting that hospitals, at least in the United States, have started to do this, or at least have put a foot in the water, and they're often associated with rules that Planetree doesn't use. If you look at the Johns Hopkins, a major hospital in the United States, there are a list of criteria that actually differ in each region of the hospital. So they have perioperative services, emergency department, the intensive care unit, all with their own set of instructions. But in general, it's carefully thought out and is a major departure from what we've seen in the past. Hearing our patient talk about her experiences in multiple hospitals made me think of a quote that appeared in a textbook some time ago. That hospitalization is the worst form of incarceration you can inflict on the non-criminal, and I think that's fairly accurate. Planetree itself was started by a woman who said she had an excellent medically correct experience in a hospital, but it was horrible, and she probably did have PTS afterwards that she turned around and used in a very constructive way to actually start Planetree. Planetree itself is founded on the concept of patient empowerment as a form of patient-centered care. There are different forms of patient-centered care. That was the original concept of Planetree and remains so, which is why Planetree pushes the envelope a little bit for requiring 24-hour care in designated hospitals, or 24-hour visitation.
Thank you, Steve. So these were some of the concerns and issues that we do hear, and I think between the two of you addressing each of these issues and how you've approached some resolution or some of the things that still present particular challenges. Carol, do you want to go first?
Sure. When you start talking about, one of the ones that you hear pretty frequently is about privacy concerns. And part of the privacy concerns can take place if you are in a semi-private room, which some of our hospital rooms in the United States still have 2 beds in them. And so that can be an issue. One of the things that I think we've found is that you just need to have the discussion with the patient. So if the patient wants family in the room, people are going to see that this is maybe a little bit different than if you had a private room. And so just talking with both of the patients, seeing what their needs are. I know that in our facility, if there was a large family of the patient in the other bed, or if the other patient felt uncomfortable having somebody staying in the room overnight, we did everything we could to kind of change rooms around to make it so that it was possible for both patients and met both of the needs. I think Steve will talk a little bit more about ICU, and so I'll leave that for him. Psych is another place. Now, I will tell you that we do patient-directed visitation in our psych hospital. We have 2 units. It's not a large hospital, but we have 60 beds. Half of them are adult and half of them are youth. And while we don't allow families to stay overnight, that is kind of one of the expectations and the guidelines that we do have, because we do still have semi-private rooms in psych. We, as long as visiting hours are scheduled and as long as the patient isn't in the middle of group, we allow families to come in without any issues. So we've gotten around that, and it has been very positively received. Steve, do you want to talk about ICU at all?
Yeah, and also our experience with semi-private rooms. Actually, the nurses have come to us confused about this, because at times when there were more than 2 visitors in one room, clearly the patient was benefiting, but the patient in the adjoining bed was not. So they didn't want to hurt the patient who was benefiting, but they didn't know what to do about the other situation. So we've done it on a case-by-case basis, and I think some hospitals that have limitations of 2 people at a time in a room are on the right track as well. We've in the ICU, again, there are different ways of doing it. Some ICUs allow open visiting to significant others or designated care partners. What we do at Stanford Hospital in Connecticut is that we had some pushback initially from the physicians who were rounding, and so we declared 2 2-hour periods a day, in the morning and late afternoon, when physicians and nurses were rounding, not to shut off the visiting hours, but to inform the family members and friends that during these 2-hour periods, you're welcome to visit, but you may not be able to talk to the nurse or doctor who's regularly taking care of your loved one, in order to get more specific answers about their status. So with that proviso, we allow 24/7 care.
And Steve, in our ICU, we also allow the 24/7. We also do have the 2-hour periods in the morning and in the evening. And what we have communicated that is that it's quiet times, and that we use them to promote rest and healing, and that while the families are always they take priority and they're always invited to be part of it, we do encourage them to use that time to refresh and nourish themselves, either in the cafeteria or just walking on a trail or just something to get outside. The other thing that we do if they do want to stay is we do try to keep the doors closed, because that is a time during report that information is being shared that might be heard.
Some of the studies that have been published, although most of them are not scientifically rigorous, but this is a difficult thing to study. And that is that although there's no infection, there seem to be more bugs around with visitors, but the patients don't seem to have an increased incidence of infection. And there's no question that the stress levels of the patients are lower. Of interest, heart rate and blood pressure go down with visitors, but go up with nurses. So I think there's information there, especially in the cardiovascular parts of the hospital.
One of the things that we end up doing is when a patient gets admitted, especially to the ICU, but to other areas also, is that we really encourage them to come up with a visitation plan. And the first part of the visitation plan is we ask people if they would like to have a care partner. And for us, what that means is the patient may designate somebody who they want to be a member of the healthcare team. And this is maybe a little bit more formal than a family member who comes and goes. The care partner is really welcomed as a member of the team. If they want to stay overnight, they certainly can. In our hospital, we give them a badge. They get the employee discount in the gift shop and in the cafeteria. And we include them in the education and the teaching. And it's especially for those people that want to participate in care in really a different way. So upon, if we have not designated a care partner before the patient comes in the hospital, we do talk to them about a care partner program while they are in the hospital. When we do that, we part of what we are doing really is encouraging a certain group of people to be there or a certain person to be there, but then we do a lot of the explanations about the limitations or about a visitation plan that might be most appropriate. One thing I forgot to say that I think is really important is that all visitation is patient-directed. So if the patient would say, I do not want any of my crazy family visiting me, the nurse would really work to advocate for the patient. And they would figure out a way to make the patient's wishes be complied with. I can't say that really ever happens, but we do very clearly make sure that to see what the patient does want before we visit a plan. Steve?
Yeah, it's fairly easy to Google the concept of patient-directed visitation because what will come up will be the guidelines often or the instructions that hospitals give to patients. Most hospitals have this now front and center, or the ones that are doing it, because they frankly are very proud of doing this and feel, as we do, that it's a more advanced form of patient-centered care. And it takes a fair amount of courage. It is more difficult for the nurses because the nurses often are the ones in the middle who have to kind of modulate the flow of patients into a room, need to keep track of the other patient in a semi-private room, and when appropriate, to also insist that the visitors abide by infection control for patients who require visitors to be gowned and gloved or on special precautions. We have had an interesting recent discussion. I'm sure, as you're doing, we're looking hard at our hand hygiene percentage among the different members of our hospital. And it took us a long time. We're very proud of the fact that we're up around 95 or 96%, who we actually have observers to look at hand washing. But we never bring this up for the flow of visitors into the room. And although our drop in certain infections like MRSA has been impressive and is temporally related to our hand hygiene approach, it doesn't sound unreasonable to at least encourage in some way visitors to take advantage of hand hygiene. Perhaps one of the most difficult situations we have is in the area of encouraging physician support under some circumstances. And as I mentioned before, the ICU was the most sensitive one. Most of the physicians are not that aware of the literature, and very frankly, there aren't a lot of really strong articles supporting this concept. But I think the physicians understand the importance of family contact, and it turns out the literature is actually quite interesting because even in neonatal units with siblings visiting, it's not just important for the patient, but it seems to be important for the family members or siblings who are more relaxed in terms of understanding exactly what's going on. For better or worse, at least they have. It's not left to their imaginations, and so there's this feeling of doing something by being present, and so there's benefit in not just the patients. And a number of articles address the specifics of the family members. Now, one thing I would want to mention that there was a pushback literature really before 2004 or so that talked about patient exhaustion, and I think this is something that I've certainly seen. I'm going to assume that most of you have seen it also, associated with open visiting hours and well-meaning family members or friends who kind of overload a patient. I think that's why the concept of patient-directed visitation rather than open visiting hours is an important one. That if the patient is conscious and aware, then and they're able to make decisions, then we abide by their decisions. And if not, the person who's the caregiver for the patient or significant other does that type of direction. So I think we need to move this out of past prejudices and to understand more that we need to put ourselves out in the healthcare industry to a greater degree to make patients feel more comfortable. I think we underestimate the emotional trauma that occurs. We don't look at it on a regular basis. If you read the literature, it's a little frightening. And I think that there needs to be more discussion in a multidisciplinary fashion to see how people can work together, put themselves out a little bit more, even though things are so hectic now in the hospital, to comfort the patient. And this is as good a way as any.
Thank you, Steve.
One of the things we have found is very important is for there to be consistency between shift to shift. And I really can't stress this enough. You certainly want to have everybody's support when you go in to implement patient-directed visitation to begin with. But on a day-to-day basis, it's important to have some kind of document that the nurses can share between shifts, or if somebody's off for a day, a new nurse coming on, so that there is some consistency. Early on in our implementation, actually, it was kind of funny because the staff had no problem allowing the patient's pets in the unit, including ICU. They had absolutely no problem with inviting the family in if it was a code 99 or emergency situation, inviting the family into the room so that they could kind of see what was going on. But they had more trouble with the patient-directed visitation. And upon a lot of conversation with people, it was just that that not everybody was doing it the same. So one shift, a nurse might be very lenient. The next shift, the nurse might be stricter because maybe something was going on, but maybe she was just more comfortable with that. And so that was really the issue that we had to address to make this part of the culture and the way it was done every single day. So we always do, on our care plans, we always talk about what is it that the patient wants, knowing that it can change actually from shift to shift and day to day, but what are they comfortable with? They make a big effort to know the family so that they can have some communications with them if they need to say, you know, it's time to leave now, and patient needs some rest, you know, whatever they need to say. But then we don't end up with the good nurse, bad nurse syndrome. And so that ended up to be something that was very helpful for us.
Right. Thank you, Carol. And then the other important piece of that is how you engage with the patient. I think you talked some about this as well with discussing who with them and the documentation. Steve, you talk about that need for balance and the rest period. What about the educating the visitors? How have you managed, what have you done with that regard?
We have this in the admission packet. We do discuss this with visitors, but I have to say that since visitors are coming in during most of the day at any time, it's sometimes hard to capture them. and give them the information, even though it may be written in the brochure for the patient. So I think this is something that we probably can do a better job on, and I think especially if there's a care partner or a spouse, we also trust that they inform their friends both on the outside as well as those who come to visit unannounced.
I would agree with what Steve has said. Also, especially in the ICU, the patient-nurse ratio is less, and so the nurses are typically around. But you don't want to have the nurse chasing after somebody going into the room, so they do try to intervene before somebody that they don't know goes into the room to kind of discuss the plan with them.
Great, thank you. And then some of the specific considerations for you, Carol and Steve, as you prepared for designation or looked at this policy in place. I know one of the big ones that always comes up with any policy that I've ever worked with is, does it actually reflect what your practice is? But with the visiting policy, there are some other things just to be aware of.
Well, I think, for instance, we have a very active pet program. We have so all actually dogs of assorted sizes, but we haven't yet been faced by someone who wants to bring in their pet, and the pet turns out to be a horse or a sheep. So I suppose there are limitations on balancing policies depending on the reality of what is reasonable under the circumstance. I think that almost everything is negotiable. And even though the word quiet time appears on many hospitals' brochures, and yet they'll still say 24 hours under special circumstances can be allowed, and Planetree designated hospitals basically say it's 24 hours as desired by the patient. I think there's always a certain aspect of negotiation, especially if there's a patient who has a visitor who's disruptive or a little bit agitated even by how they deal with the patient. So we keep an eye on, and at morning rounds, we often discuss whether a visitor is maybe doing more harm than good. That someone may mention, family is great, but there's a cousin who came in from California and is extremely upset and comes in crying. It's as though the patient now is taking care of the visitor. And so we gently try and talk to the family members or friends who we think are not necessarily serving the patient. We try and explain to them how they may be more supportive.
Great. Thanks, Steve. One of the things, too, we haven't really touched on that much is how the environment can really support or enforce the policy, reinforce it anyway. I know when I visit a facility and they tell me that they have patient-directed visiting, and then I walk around and I see signs that publish visiting times, big no-enter signs on the doors of ICUs that are not at all welcoming. We talked about announcements that may go overhead that's usually been discontinued, but sometimes just the access itself is not particularly welcoming. And then with regard to 2 patient rooms or more than 2 patients in a room, then how do you accommodate other family spaces to allow the patient, if they are able to leave their room, to go visit with family in another space, or some other accommodations that can be made that make the family feel a part of the care as well?
Easily from an environment perspective, in the patient rooms, as we have designed our rooms and remodeled our rooms, we definitely try to have a nursing space, the patient space, and then a family space. And if you can design that, if you have the luxury to have some space to be able to put the family, you can place them in a way where they can step out of the patient space easily and not be in the way, but still be able to remain in the room. So we have done that. We put the sofa sofas in each one of the rooms. We have places for wireless, so that they can do some of what they may want to do during the day. So, try to make it as easy as we can in the room, both for the family, the patient, and the nurse and physician. So that's an easy way to talk about environment. We have looked at all our signage and have taken down any kind of signage that says no visitors or no visiting or stay out. We've taken down all those signs because I think that that's not very welcoming and it does raise some questions.
We're actually building a new hospital, and it's taking into account all the Planetree concepts. One of the things we do every time we do a renovation in the hospital we have now is that we expand the nutrition area and put a little cafe table or two in whenever we can. So it's inviting for a patient to sit down with a family, or a family to sit down by themselves and take a break. So any way that you can be creative in your own environment. And, of course, it's well understood you can't simply walk in and create space where it doesn't exist. But certainly, if you look critically and take a walkthrough with a group of people, you can usually come up with some suggestions that are inexpensive or even cost neutral.
Great. Thank you, Steve. I have my eye on the clock as well as facilitating this. I'm also the timekeeper, so I'm keeping a close eye on there. We are up against the clock, so I'm going to leave my email address in the chat window if anybody has any other questions. I do just want to leave you with these final words. I happen to be on a redesignation visit, a hospital that had been designated and their 3-year time frame was up, and it was time to visit again. And this was something that I heard from Robert, an ICU patient at that particular hospital who had been in for 2 weeks. Clearly, the ability to have visitors, people stopping by who he hadn't seen for years, he commented in some cases, and he really became quite emotional as he was sharing his particular experience. So with that, I apologize that we've gone up against the clock. I figured we would with only 45 minutes. It's such a short time for so much information, but we did want to give you a really good overview of how this can happen in your facilities. As I mentioned, I have included additional resources for you in this slide set, which I will send out with a recording. And there are other specific to Planetree resources that also address this issue. The Putting Patient First Field Guide, which is our 3rd edition of the book, is available, and then other articles and, of course, our website. So with that, I would like to thank you and thank Steve and Carol, both Carol. Greatly appreciate everybody being on our call with us today. And
thank you all for joining us.
Yeah, thank you very much.
And as I mentioned, I have put in my email address in the chat window. If anybody has any questions for any of us, I'll make sure that we get their appropriate questions and we'll get back with you. So thank you all again very much, and I hope that we will meet again. Thank you.